السلام عليكم ورحمة الله وبركاته. إخوتي الأعزاء، نبدأ لقاءنا النهاردة مع حبيبنا الغالي وعدونا اللدود، الصديق اللدود، عصب الوش، the facial nerve. The facial nerve, as we all know, is that nerve that's responsible for the movement of the facial muscles, and as such it is considered the face of the person through which the others communicate and see and feel the speech and words of that individual. For the facial nerve, we know that it arises in the main nucleus in the bones, and as we start to talk about its paralysis and it's the type of the traumatic paralysis, we need to revise few anatomic landmarks and few anatomic points just to remind ourselves with the cause, origin, and the pathway of the facial nerve. This is my hospital where I used to work for several years. I'm still attached to it, like it, and we shall revise the three segments of the facial nerve: the motor root, which arises in the bones, with the sensory part of the facial nerve, that is the fibers carried by the chorda tympani. It comes from the CPA through the internal auditory canal here, and then it relays its fibers of the sensory, the gustatory, in the geniculate ganglion, where it receives and sends fibers through the greater superficial petrosal nerve. That's the geniculate ganglion, and this is the labyrinthine segment. This is the tympanic segment. That's the first genio at the geniculate ganglion, the second genio at the end of the tympanic segment. Here, at this point, the blue point, it rests the tip of the short process of the incus, pointing here to the second genio of the facial. At the second genio of the facial, 1 or 2 millimeter lower down, arises the nervatus stapedius. So if we have a facial nerve trauma or cut before the geniculate ganglion will have also manifestations related to the greater superficial petrosal nerve fibers loss, including the taste, including the lacrimation as well. And here at the second genu, cut above the second genu will spare the greater superficial petrosal nerve. This point we'd like to remind ourselves because it carries significance when we ask about the history of the patient. And here, the nerve to stapedius. Any cut below or peripheral or caudal to the nerve to the stapedius muscle will not affect the function of the stapedius, so we'll find in immediate symmetry, we'll find acoustic reflex is intact, but above, the acoustic reflex will be lost. As we go down, the chorda tympani exits from the facial nerve above the stylomastoid foramen, somewhere between the fossa incudis and the stylomastoid foramen. It bears the point of exit from 2 millimeter just above the stylomastoid up to 6 millimeter or 2 millimeter below the fossa incudis. And just as it goes out the stylomastoid, we'll find that the nerve to the digastric posterior belly and nerve to stylohyoid muscle. After giving off these two branches, usually the nerve divides into upper and lower trunks. These upper and lower trunks branch into the muscles of the face. This is a representation, diagrammatic representation of the course of the facial as it comes out from the medulla. These are the two branches, the facial nerve with the chorda tympani. Here at the geniculate ganglion, it gives off and receives fibers through the greater superficial petrosal nerve, which comes and relays from the pterygopalatine ganglion. The facial nerve goes posteriorly in the medial wall of the middle ear until it reaches the fossa incudis, then it turns down vertically towards the stylomastoid foramen here. And at this point, 2 millimeter around or shorter than this, it gives off the nerve to stapedius muscle. This is the second genu, and here is the most common point of traumatic otologic trauma or otologic surgery trauma to the facial nerve. And here the facial nerve has got characteristic feature. It becomes a rather than being cord-like in the tympanic segment and the vertical segment, it becomes flattened here. This flattening of the facial nerve at this point exposes it to trauma of the burr during mastoidectomy and particularly during the posterior tympanotomy surgery. And the vertical segment is cord-like, and sometimes in rare occasions the extracranial part of the facial that divides into upper and lower trunks, it divides in vertical canal of the facial nerve. And we'll see that in a CT scan in few moments. As for the causes of the facial nerve palsy, There are several causes, as we all know, either congenital or traumatic, inflammatory, and neoplastic lesions, as well as the Bell's palsy known as the idiopathic facial palsy. The symptoms collectively can be said as facial asymmetry, right or left side, dry ear if the greater superficial petrosal is involved, drooling of the saliva because of the poor control of the orbicularis oris, difficulty of chewing food because of the inability to keep the vestibule of the mouth closed to allow creating and managing the food bolus between right and left without being expelled outside of the mouth, as well as for those who can whistle, the loss of ability to whistle with using their lips. The symptoms and signs are very obvious, and as such we need to grade the facial paralysis so as to study and contribute to the scientific evidences of different lines of treatment and to exchange information about the patient. There are many different classifications and grading of the facial nerve palsy. One of them, the most famous and most used classification I personally use because it's clear and easy to classify the patients into its grades, is the House-Brackman classification, known as HBG, 1 up to 6. So grade 1 House-Brackman classification means that the patient has got a normal functioning face, equal, no asymmetry whatsoever between right and left, can open and close the eyes, can corrugate the brow, can push and close the lips together and push them forward, can close the eye palpebral fissure against resistance, and can blow the cheeks as a balloon. So this is the grade 1. If we talk about a patient examined for his facial nerve integrity, we classify him as normal, then he is grade 1, House-Brackman grade 1. The grade 2. The grade 2 is a bit difficult and easy at the same time, because it shows, and I will show you a representation of this, the grade 2 has got a minimal asymmetry between right and left halves of the face. These differences are not obvious to the non-trained and are not obvious to non-medical staff and are not obvious to the family and relatives of the patient. However, the patient himself can recognize, and a trained doctor can recognize. I will show you examples of this. Grade 3, there's obvious asymmetry between the right and left faces, regardless you are a doctor, regardless your training level, regardless whether you are familiar with the patient or not. It's just obvious to the viewer, to the observer, that he's got difference between the right half of the face and left half of the face. when we go to the grade 4 and 5 and 6, we'll see obvious differences. Let's talk about the grade 6. Grade 6 is very easy to diagnose. There is asymmetry between right and left. There is obvious sagging of the cheek, obvious sagging and closure of one eye versus the diseased eye. You can see the white colored sclera while at rest. So these are fundamental differences that allows you to differentiate between grade 3 and grade 6. Grade 3, there is a obvious difference, but there is no sagging, no flattening, no loss of the frontal corrugations. But in grade 6, there is sagging, there is loss of the frontal corrugations, as well as obvious visible white line of the sclera. That leaves us with the grade 4 and the grade 5. The grade 4 and the grade 5, the main differences is the ability to control the facial muscles against or without extreme force and with extreme force. If minimal force is required to elevate the eyebrow, to close the eye, to move the lips without exerting much force by the patient, that's grade 4. Grade 5, of course, it comes to the mind that it is not fully closed even with maximum effort from the patient. So there are 3 differences, important differences, that allows you easily in exam, during examining the patient with facial paralysis, to classify him which grade he belongs to. From any textbook, you'll find this table that classifies the patient grade 1, 2, 3, 4, 5, 6. Severe dysfunction, that means inability of eye closure, elevation of the eyebrow, and ballooning the cheek even with extreme effort from the patient. Here are 2 examples. On the right side here, you'll find a lady. Sorry for masking the eyes because I did not like to be recognized. Here we can see the nasolabial fold has been lost. On the other side, on the right side, is still there. The wrinkles in the eyebrow on the left side has been lost, while it is still preserved on the right. Sagging of the cheek and lowering of the angle of the mandible, angle of the mouth. That means this lady is grade 6. Let's compare her to that man. That man, he is not yet examined, sitting quiet with the following observations. Here, the eyebrow wrinkles, the front wrinkles, are still there, though less obvious than the right side. Less obvious, more obvious, I mean, than the right side. Here, your eye closure is incomplete, while here it is complete. The nasolabial fold still little difference between left and right. The angle of the mouth is not yet very obvious to the non-medical staff, though it is obvious for the medical doctor examining him. That's grade 3, and this is grade 6. The diagnosis. We can use Schirmer's test just to identify the level of the facial nerve palsy, whether above the exit of the greater superficial petrosal or distal to the exit of the greater superficial petrosal. And then you can take the Schirmer's test that is performed by using the litmus paper of 25 millimeter length, width 5 millimeter, bent into 2 halves. At the first 5 millimeter and left lengthy the 20 millimeter. The rest, we take the 5 millimeter part to be into the fornix of the ear, of the eye, for 5 minutes, and we calculate the change of color or the wet or the absorbent paper, and we compare them right and left by calculating the length of the change of color of the litmus paper. The normal means that is 15 millimeter or less wetting of the paper after 5 minutes. I mean of more ASF. And mild, that's 14 to 9 wetting of the paper difference between right and left for 5 minutes, and moderate and severe. Electrophysiologic data can help the degree of regeneration rather than the degree of degeneration. However, it can measure the degree of degeneration, but in clinical practice, when we see the facial nerve palsy, we need more to know the regenerative process rather than the degenerative process. The EMG, just to evaluate the muscle viability, to test for the motor endoplate liability. The electroneurologic tests, these are just to measure the nerve activity and viability. We use the CT scan to identify the course of the facial nerve, to detect disease, trauma, inflammatory, as well as neoplastic or surgical trauma. In this slide on the right side, we can see that the facial nerve has got its, this is a very rare case, when you see that the trunks of the facial have divided and split intratemporal rather than extratemporal at the stylomastoid foramina. And this case has got 2 stylomastoid foramina and 1 main trunk compared to the smaller trunk coming out just posterior in this parasagittal lateral oblique 30-degree lateral oblique CT scan of the temporal bone. Here we can see and recognize as well the facial nerve at the second genu, and here the stylomastoid foramen. Okay? In this case, we can see that we study in that case we study the anatomy of the temporal bone, because we need to interfere surgically for this patient at some point or another. We can see here that the patient has got corner septum with very small antrum, and here we can see that is the tympanic membrane, and we can see here tympanosclerotic patches, as well as in this cut, the coronal cut. This is the internal auditory canal, superior canal, lateral canal, the malleus, and lateral to the malleus there is a tympanosclerotic patch. This should be seen and observed before surgery. The treatment usually is the treatment of the cause, whether it has facial schwannoma should be resected, removed, and then the facial nerve should be grafted. The care of the eye never forgotten, because facial nerve is a drastic complication, a drastic disease. If you add a comorbidity, you'll get in trouble if it were due to surgical intervention, because dryness exhibited during the paralysis period with the infrequent eye closure, with the infrequent or the little lacrimal secretion, will lead to dryness of the cochlea, of the cornea, with keratitis, ulceration because of minor trauma, loss of vision. So the care of eye is very important, as much as it is important to rejuvenate and correct the facial paralysis with grafting, for example. Artificial tears, just to overcome the dryness because of the loss of the chorda tympani function and the great superficial protrusion. By eye ointment, particularly eye ointment, to protect the eye against the draft of air, the foreign bodies, and to protect the cochlea in particular. Sunglasses when you go out, when the patient goes out in the air, windy days, they will carry dust and particles into the eye, and then it gets conjunctivitis or keratitis with loss of vision. We come lastly to the surgical repair and reanimation procedures. Here, quite obvious the differences between the right and left faces of the patient. We can see here there is accentuated nasolabial fold, loss of the nasolabial fold, inability to open the mouth on the right side, while he could open the mouth on the left side. Loss of corrugation on the right side of the frontal corrugation while preserving it. The eye is not open. The eye is not is open and not closed, while the left eye is closed. Here we have done the cortical mastoidectomy, and at this point the fossa incudis, this short process of the incus, the incudal buttress, and here the shadow of the facial nerve in its vertical segment. So this is the vertical segment of the facial, and this is the lateral canal. This is the horizontal facial, the lateral canal prominence, the fossa incudis, short process of the incus, vertical facial, and here we can see the promontory, and this is the round window. Here is the pyramidal eminence with the stapedius tendon muscle. And then we go to this diagram. After delineating the dural plate, the sinus plate, and the digastric ridge, we can see that's the dural plate, the lateral sinus, and here the vertical segment, second genu of the facial. Here is the cut end, and this is the graft. We'll discuss it in very few minutes. I see some colleagues say that these photos are not very clear. Are they now? Is it obvious by now? So please, if anyone can comment about the clarity of the photo, I will be glad. Here is the cortical mastoidectomy. The facial nerve vertical segment has been identified and found traumatized. We create and we got a graft from nerve. Is it zoomed enough, or shall I be like that? If anyone can okay, is it clear? And here the other side, the other photo, it's a microscopic photo after doing the cortical mastoidectomy, posterior tympanotomy, identification of the facial nerve. Here is the facial nerve. Here is the facial nerve, second genu, and here is the incudal buttress, fossa incudis, short process of the incus, body of the incus, superior incudal ligament. Okay, so let's see how we do the grafting. Here the arrows show the tip of the mastoid, and the retractor here is at the level of the sternoclavicular joint at the anterior border of the sternomastoid. The incision has been taken. The incision has been taken. Skin subcutaneous tissue at the midpoint of the posterior border of the sternomastoid. We could identify the greater auricular nerve. Here, the greater auricular nerve has been found in this particular patient, divided in two segments, just as it arises on the posterior border of the sternomastoid to go upwards on its lateral surface. Here is the point, the mastoid. The mastoid, after being opened, we find here the arrows shows the first arrow up shows the antrum, and the second arrow shows the lateral canal prominence, and this white part is the short process of the incus with some tympanosclerotic patches. Here, the cut end of the facial just below its second genu, and here the lower end, the distal end of the facial nerve at its vertical segment. Here. So we have about 3 millimeter, 4 millimeter length between these two cut ends. Someone would ask, how could I measure this? As we all know that we use the burrs to cut through the temporal bone, and these burrs come in diameters of 1 and less than 1 millimeter, 2, 4, 5, and 8 millimeter diameter. These diameters, we can use them to measure the distances. So this point of trauma of the facial nerve has adopted a diameter of 5 millimeter burr. So we could measure that the length of damage and to the facial nerve was about 4 to 5 millimeter. So we have to take a graft that overcomes this wide area of tissue loss and give it some extra length so as to lay in a lazy fashion in the mastoid to allow healing without traction, and to allow, if you decide to use stitches, to allow stitching the facial nerve with the graft without tension. Here is the proximal end of the facial anastomosed with the graft, as you see. This is the length of the graft in a lazy fashion, laid down to anastomose with the distal part of the, or the cut end of the facial nerve. And these two segments, the distal and proximal, are approximated together by using the graft. However, there are different types or methods to overcome the distance, as long as these distances is not as big as that one in the picture. How to overcome this? How to fix the graft, the cable graft here between the two cut ends of the facial? We have different techniques. And when we listen that some technique, there are many alternatives, we can accept the idea none of them is ideal. So none is the best is the general rule when you find different techniques. For example, stitches are not applicable in all cases because of the intricacy or the difficult anatomy, because of inavailability of the stitching material, or the nerve is not very well stable, like in the CPA. We cannot stitch it easily in the CPA after acoustic neuroma resection, for example. Otherwise, you can use tissue glue or platelet-rich plasma. We can use it as autologous a tissue glue, or we can use a vein tube or a fascia from the temporalis to be laid on the grafted segment of the facial nerve. So we can use different methods to fix the facial nerve graft in place. You can either stitch with nylon stitches, 010, that is used to close the cornea after corneoplasty or keratoplasty, and it is better. For myself, I use 1 or 2 stitches to stitch the graft with perineurium to perineurium at position 3, 9, or 6 and 12. I do not use more than this. However, some other surgeons prefer to use it continuous perineural nylon stitch the same time. But I find this is difficult, and I find it jeopardizes the integrity of the nerve, particularly the facial nerve, which is a bit slimmer than other peripheral nerves. As for the plasma-rich protein, the platelet-rich plasma is easy to use by taking 3 to 5 milliliter of patient's blood in in some solution we take from the laboratory, and then we leave it without stirring it in a sterile test tube until we find a supernatant fluid, clear, yellowish to clear plasma filled with very much of the platelets that allow sort of adhesion between the cut ends of the fascia and the graft. Next to this, I would like to say few points. Facial nerve is our friend, is not our enemy. Our friend we should look for, identify positively at certain points. These certain points we all should know by heart. In the middle ear, at the processus cochleariformis, it starts its second segment. At the fossa incudis ends the second segment and starts the third segment of the facial. In the labyrinthine segment, that is in the internal auditory canal, it starts by the infundibulum and ends at the geniculate ganglion just above the crista falciformis. This is part of the anatomy we face, and it is mandatory to identify these in temporal bones before you indulge into surgery to the facial nerve, or you watch and gradually build up your experience, but be careful. Thank you very much indeed. Now I'm ready to answer what questions you might pose. Here is my colleague, Dr. I've seen a question here from Professor Ayman Fouad. What are the criteria to operate or to conserve? What are the nerve conduction studies? The nerve conduction studies are very dubious to understand and evaluate. We are, in this context here, in this lecture, we are talking about the traumatic facial nerve. The traumatic facial nerve has got no criteria. Once you find a facial nerve trauma and you identify that it has been traumatized during surgery, or it has been traumatized during road traffic accident, for example, it means that you have to interfere. It means you have to interfere. And never forget that the patient, if he is today at grade 2, in due time, in 2-3 days, the edema that resulted from the trauma can turn it into grade 3 or grade 4. When the facial nerve function degrades over time after a definitive type of trauma that has been recognized, that has been seen in a CT scan, that has been intraoperatively, that has been expected after doing sort of surgery, any sort of surgery in the middle ear or the mastoid or in the CPA, that the patient has developed mild facial palsy, you must identify the level, you must decompress the facial nerve because it is expected to deteriorate over time. Don't wait until it deteriorates. Note here that I'm talking about the traumatic facial. I'm not talking about Bell's palsy, for example. No, unless you have a definitive type, definitive history, definitive examination, definitive CT scanning of the patient, you identify trauma. Once you identify the trauma and the patient develops the facial palsy, decompress, because the edema will continue to develop, and over time the patient grade moves from 2 to 3 or from 3 to 4 and so on. So there is no special criteria to operate in these conditions. I'm talking about traumatic facial. You have history and examination that tells you you have injured facial. Injured facial, you must decompress. I wonder whether there are any other questions I'm glad to ask or to answer. Okay. The optimum timing for facial repair. The optimum timing of the facial repair in cases of traumatic, the earlier the best. The earliest possible point of time, because as we have just mentioned, trauma means edema, strangulation of the facial nerve. Strangulation means poor recovery and limited success rate of repair. There are a few sophisticated points about the repair. We can do the repair point to point, that is, if there is no tissue loss or the facial nerve can be released from the tympanic segment as the vertical segment and got approximated to each other. That's one point to point grafting or suturing. The other type is the grafting. The grafting with a cable graft, that is 2-point stitching or repair. 2-point stitching of repair requires that you have a donor nerve that's easily recognized, easily removed from the area of the surgery, and most probably would be the greater auricular. Sometimes we can use the sural nerve lower in the lateral aspect of the lower limb, and this, in cases we expect that doing the surgery will have to deal with the facial nerve with possibility of its injury. So another team will save the time and create the sural nerve graft. However, this sural nerve graft is a bit disadvantageous, because if the patient is diabetic, he would lose sensation over the lateral 2.5, three and a half toes of his affected limb. So I personally prefer to use the greater auricular because it will not harm the patient if he develops or if he were diabetic, for fear of developing trauma to the lower limb and resulting into diabetic foot or so much of the comorbidity. So that's the cable graft, and the cable graft can connect either distal to proximal parts of the nerve, or we can take a cable graft, a bifid one, that's like the case I just presented, when the greater auricular nerve has got two trunks. We can use them to 2-point anastomosis. 2-point anastomosis, the 2 points will go for the upper and lower trunks, and the 1-2 point will be the vertical segment of the facial with the graft. So these difficult situations come, or we can face, for example, in malignant tumors of the parotid, when we have to sacrifice the facial nerve. We can use the cable graft to the other ends of the facial nerve, the non-sacrificed or the saved branches of the fascia. As for the late onset or lately discovered or lately diagnosed or lately seeked for treatment facial paralysis, particularly of the traumatic facial paralysis, it has been calculated that the motor end plate can survive up to 9 months post-trauma. So after 9 months post-trauma, the motor end plate will not be responsive to any neuronal stimuli, even if the facial nerve could be recognized and grafted. So the better, the earlier you can graft the facial, the better would be the results. Now I would like to ask few questions. If anyone can help, I would like to ask whether or not, or what is the preferential technique of covering the grafted facial? Would you like to use vein graft used as a pantaloon to go around?
It's 22 hours.
To go around the facial nerve from the after. How we do that? We get the vein from the dorsum of the hand or the antecubital fossa. We take it and introduce the cut end of the facial through the tube to the outside, and then we stitch it to the nerve graft, and then we replace to cover the grafted area. In these situations, we assure that vascularization will help and protect at the same time the facial nerve from the nearby infection. So when do you prefer add antivirus to the cortisone in treatment of facial palsy? Unfortunately, in the facial palsy of idiopathic origin that's named Bell's palsy, Up to now, it has got so many discrepancies in views and the literature, no solid evidence of certain type of treatment alone can allow or can help complete recovery of the facial nerve in Bell's palsy. It has been said that in 18% of cases it recovers spontaneously. In the 20% of the cases, it needs some treatment. These some treatments vary from facial decompression under certain circumstances or antiviral or steroids. But as long as any of these treatments cannot be evidenced that alone cause complete recovery, it gives us to the first sentence I said, as long as there are too many ways to reach Rome, none of them is the best. Because of the facial nerve function is very important, personally, I prefer to offer my patient the best by offering him the steroid, the antiviral, and if the facial nerve deteriorates over a week, I would advise surgical decompression. Nevertheless, do not forget care of the eye. Do not forget care of the eye. We, as doctors, we usually forget the care of the eye. Please, when you see a patient with facial nerve palsy, do not forget the eye. Well. When to test the nerve after repair? Do we need to test the nerve after repair? I find no benefit of testing the facial nerve function electrically or doing electroneuronography or doing electromyography after the grafting, because what I need to see, not the electric responses, I need to see active muscle facial expressions, so the patient will tell. By the way, I forgot to tell you that after grafting the facial nerve, we expect 1 millimeter per day growth of the Schwann cells from the proximal to the distal end of the facial nerve. So a loss of 3 millimeter means that, or 3 centimeter, means that the patient, if it's going to heal properly, will regain function in 1 millimeter divided on 30, that is 30 days time. If we keep him on suitable neurotropic treatment, vitamin B6 and 12, that will let us expect recovery by the 30th or after 30 days up to 60 days. So it differs from one to another patient, but it has been calculated as such, 1 millimeter growth rate per day. Yes, you are obliged to open any case traumatized facial nerve after surgery. If you did not identify during surgery and you did not repair during surgery, and the patient wakes up from general anesthesia or local anesthesia with facial palsy, you should go back, remove the pack, open the mastoid, identify the facial nerve, decompress, even if you need to open the sheath of the facial nerve, not just to remove the bony walls of its canal. So if you are not sure that you did not or you did injure the facial and the patient comes out with facial nerve palsy, make sure that you did not inject local anesthesia with xylocaine intracanal in the postauricular incision, because sometimes when we infiltrate, particularly in cases under local anesthesia, we infiltrate the skin periauricular with xylocaine. This xylocaine can cause immediate post-op facial palsy. This usually recovers by 48 to 72 hours. But you can revise the situation by going through your recordings, your memory. What if you have struck the facial nerve by second knife, by the burr, or by traction, or by the whatsoever means. How can we avoid the injury of the facial nerve? To avoid the facial nerve injury, first you must, I'll say it again, you must say it thirdly, you must know the anatomy. Then you must follow the steps of the cortical mastoidectomy. The steps of the cortical mastoidectomy are three main ones. One, open the mastoid cortex. Two, identify two important landmarks, dural plate, sinus plate. Go in between, that is the sinudural angle, until you reach the antrum. In the antrum, you identify the prominence of the lateral canal. If you go a little bit further forward towards the nose of the patient, you go into the posterior attic spaces, that is the adductus, where you can identify the short process of the incus. And as you identify the short process of the incus, you go a little bit lateral and inferiorly towards the tip, you create the incaudal buttress. Here at the incaudal buttress, you can gradually remove the bone lateral to the vertical segment of the fascia. A little until you see a whitish structure that shows some bleeding points. These some bleeding points are very important because it indicates, these points indicate that is you are very close to the perineurium of the facial nerve, because these are the branches of the facial nerve vessel arising from the stylomastoid artery. These are the vasa nervosa of the facial nerve. And then you go back again and follow the lateral sinus until you find the digastric ridge. When you identify the digastric ridge, you remove all the bone lateral to the digastric ridge, because that saves you hitting the stylomastoid foramen. As you go from lateral sinus posteriorly and superficial to the digastric ridge, or in other words, make the digastric ridge a barrier between you and the lower part of the lateral sinus. As you remove this, at the anterior end of the digastric ridge, you will find the stylomastoid foramen. And never be afraid of the stylomastoid foramen, because here the facial nerve has got its maximum thickness and had got it's protection from the insertion of this posterior bed of the gastric and the mastoid and stenomastoid muscle, as well as the periosteum of the temporal bone. So it has got a tough and thick covering that protects it from your burr. So we summarize that again. First, remove the cortex, then identify the dura plate, sinus plate, go between these two, its angle. The angle is the sinusoidal angle. As you go through the sinusoidal angle, you reach the antrum. As you reach the antrum, you'll find the lateral prominence, the prominence of the lateral canal. If you go a little bit forward, you open the additus, you see the short process of the incus. You go superficial again and inferior towards the tip of the mastoid. Then you identify the incuidal buttress. Go back with the lateral sinus down until you identify the gastric ridge. And here you go forward again towards the towards the external auditory meatus. As you do so, keep the gastric ridge between you and the lateral sinus. That way, I believe it's easy for anyone, if you follow the steps perfectly. I feel that you can do cortical mastoidectomy without injuring the facial. What are the indications for facial nerve exploration in cases of unresolved bells, and when to take the surgical decision? We have time frame, dear Professor Mohammed Tawfiq Tabbakh. We have time frame for intervening and decompressing the facial nerve. The time frame starts between the issue, the start of the diagnosis of facial palsy, grade 6, and ends by no recovery by the 9th month. So that's the time frame we are talking about. After 9 months, no need to decompress, because the edema and the atrophic changes will turn the facial nerve into a fibrous band and no longer valuable or no longer viable for any intervention as for decompression. The first few days, we watch the patient. If he becomes stable, we continue with him the steroid and antiviral, and we watch them. If he shows improvement by second or third week, there would be no need for surgical intervention. And then if it progresses over the 2-3 weeks and does not show any incidents, any evidence of recovery, we have to interfere and decompress the facial nerve. However, what is used to watch the patient during these period of time? From the start, we do a electroneuronography. If it shows within 10 days more than 90% of the degeneration, that means there is a necessity to intervene and decompress the facial nerve, even with incising its perineural sheath. My dear friend القاضي، أنا موجود على الفيس أهو، شايفني أكيد، أنا شايف نفسي. After road traffic accident, a month delay after the paralysis, is there any role for intervention? Yes, after having a high resolution CT scan, to identify where is the site of trauma and whether there is bone shrapnel that is compressing or forcing itself into the substance of the facial nerve. If all trauma can be facial nerve repair done, physically can be done. Whether it is useful or not, that is the question, and it depends how long after the trauma you will intervene, as you must intervene as early as possible with history of trauma, evidence of trauma, facial nerve, progressive or complete facial nerve, House-Brackman grade 3 and up, you must interfere. What about the timing to take the patient to theater? As early as possible. Once diagnosis has been done, clinically, symptomatology, signs, CT scan, you should interfere. What you will do for a complete facial palsy after CI operation. If the patient awakes with facial palsy grade 6 or grade 3 and above, and the surgeon sure that he is not, or he had not traumatized the facial nerve canal, that's a difficult situation. If you are sure, there are several possibilities. If you are sure he did not hit with the burr, there is a possibility of thermal trauma. Thermal trauma is very dangerous. Thanks God I never had facial nerve palsy post-operative for a CI, but I managed cases with this complication of other colleagues, and I had to go inside again and to decompress the facial from the second genu down to the stylomastoid foramen, because this is the most liable area for damage, thermal heat during the posterior tympanotomy. A brief about rehabilitation of the facial nerve, dynamic and static. سوري يا دكتور مصطفى، يعني لو ان انا كنت مرتبها لك كنت قلت لك فيها كلام كتير، لكن let it be the next lecture ان شاء الله. Dr. Ahmed Gamal Shulqami, in cases of trauma affecting the labyrinthine segment of the facial nerve, do we have to compress only the labyrinthine segment? In such cases, my dear, there are other problems as well. So if the patient in such cases has a CSF leak, I would advise doing a middle fossa approach to decompress the facial second segment, labyrinthine segment as well, and repair the dura. But taking care of a very important point is, has he still a functioning cochlea or not? Because if he doesn't have a functioning cochlea, that would be very easy, unless you plan to cochlear implant his patient. So in such cases, it's better to have a middle fossa approach. Though difficult and needs special tools and special retractors, but to my mind, this is the best way to decompress the labyrinthine segment safely. The success rate of the facial nerve. In my hands, the cases which I indulged with traumatic facial nerve and I dealt with, all of my cases recovered within the next 6 months after surgery, after intervention, including those of decompression only and cable grafting. The Omar Al-Rawi من العراق. Dear sir, in case of facial nerve paralysis post-accidental, non-iatrogenic, what landmark you suggest to follow? To identify the injured region in an area which can be disturbed by trauma. My regards. Dear Omar, the first thing I do is clinically examine the patient, identify the level, and then high resolution CT scan, coronal, axial, and parasagittal cuts, lateral degree parasagittal cuts, to identify the fracture line where it did cross the facial nerve. As such, I can identify the point of possible injury, and then I design my soft tissue approach and the bone work to be done. In case of decompression, what do you prefer, canal wall down or canal wall up? Dr. Ahmed Shulami. As a surgical principle, we prefer as surgeons to remove the harm and keep the anatomy and function undisturbed. So your question is, in cases of decompression, what do you prefer, canal wall down or canal wall up procedure? We apply the principle. We go to correct the pathology without or with preservation of the normal anatomy and without inferring or without causing extra morbidity or functional loss. So I would prefer canal wall up technique unless it had been already done or the posterior canal wall for some reason or another had been done and the job has been already done for me, so I cannot reconstruct it again. So I would keep it as such, canal wall down technique. In diabetic diagnosis, necrotizing otitis externa. The lower motor neuron facial lesion not improved after medical treatment. ده سؤال من الزميل العزيز الدكتور أحمد الهني. دكتور أحمد، الباثولوجي بتاع الاوتايتس اكسترنا أو النيكروتايزنج اوتايتس اكسترنا should be understood, very well understood. The facial nerve gets involved and paralyzed in necrotizing otitis externa through many different techniques or many different pathways. First, edema. Edema at its exit from the inflammation of the periosteum and perineural sheath of the facial nerve at the stylomastoid. So it's a sort of strangulation in the vertical canal. That one pathogenesis. The second pathogenesis is the toxins excreted by the bacteria involved in necrotizing intestine have its effect on the facial nerve itself. Thirdly, the microangiopathy of the disease itself involves as well the stylomastoid artery. That's the blood supply, the main blood supply of the facial. So the facial nerve suffers a anemia or anoxemia because of the glycosylated hemoglobin that will not deliver the amount of energy or oxygen required for the facial nerve function. So we have many pathogenesis in this condition. So doing facial nerve decompression in such cases, to my mind, is very important, taking in consideration the time frame we have just mentioned between the issuing time of the paralysis and the 9-month period post-operatively, or the post-disease, the post-paralysis. This time window is very important. If you interfere very shortly after the facial palsy has developed in necrotizing otitis externa, you can decompress the bone and you can incise the perineural sheath. In such cases, there are many different opinions. Let me talk honestly with you. Some will reject my policy on the assumption that the area is full of toxins and bacteria, and these will get easy access to the facial nerve axons as well. That will cause paralysis. However, I'm not convinced with this, because cases which I operated in the early phase, I repeat, the early phase, early post-paralysis period, that's the early post-paralysis period. That's what I mean by the 2 to 4 weeks post appearance of the paralysis. Because after that, fibrosis will not allow any successful surgical procedure to the patient. لا ازاي ما فيش صوت؟ لا انا ازاي ما فيش صوت يا مصطفى؟ انا سامع نفسي على التليفون التاني يا مصطفى. دكتور حسام ثابت، انت نورتنا يا دكتور حسام. Decision for surgery. If ENG give less than 90% of fibers, use steroids. حضرتك بتتكلم EMG ولا ENG؟ Electroneuronography, ENOG. This is an area of debate يا دكتور عبد الله. يبدو ان مفيش اسئلة تاني، او يمكن في اسئلة انا ما خدتش بالي منها، فارجو ان اذا كان حد عنده اي اسئلة يسألها قبل ما ننهي لقائنا النهاردة، وندعو الله انه يحمينا من الكورونا ويجمعنا على خير باستمرار. As regard الدكتور عبد الله سليمان الملا بيسأل regarding repair by fascia, is it sutured or not? دكتور عبد الله أنا I did not say a repair with fascia. الفاشيا is just used to cover the suture, the grafted ends, the graft with the facial nerve cut ends. It's not a grafting material. It's a cover to cover the grafted area, to allow permeation and new vascularization that gives nutrition to the grafted area of the fascia. Dr. Ahmed الهني بيسأل any case of facial palsy, physiotherapy is contraindicated. Physiotherapy to the paralyzed facial nerve is classified into two types, either active or passive physiotherapy. By active physiotherapy, we mean that the patient induces by himself active facial muscle exercise 5 times a day, each muscle 5 minutes. That means that he stands in front of the mirror and elevates his eyebrow, corrugates the wrinkles of the front, closes the eye, opens the eye, blows the cheek, and corrugates the mouth, kissing the air like these 5 movements: eyebrow up, corrugation of the eyebrow, opening the mouth, blowing the cheeks, kissing the air. These 5 movements, when performed by the patient, will initiate or help the rapid recovery of the facial nerve on the assumption that its cells in the medulla, in the bones, will send the neurotrophic impulses and neurotrophic hormones that initiate and accelerate recovery of the facial nerve. However, the passive, usually described by our colleagues in the physical medicine and rehabilitation, are massage, electro stimulation as faradic or galvanic stimulation, and all these methods have been proven that do not help if not inducing harm. The massage will stretch the muscles of the face to the point behind the optimum length of the muscle. As we remember from our early studies in physiology, the nerve and muscles experiment, there is an optimum length of the muscle. When it gets the stimulus, it contracts with maximum power. Shorter than this or longer than this will not give the maximum muscle contraction. So massage will induce lengthening of the muscle to over the optimum length. As for the faradic and the galvanic stimulation, these has been proven they induce motor end plate fibrosis on the long term, so they do not help regaining of the facial muscle function. Thank you my dear. نورتنا يا دكتور أحمد خاطر. يا ترى أقدر أقول أي حاجة في أي أسئلة أخرى؟ أتعشى أن يكون النهاردة في إفادة لمن شاهدنا ولمن سيشاهدنا بعد كده. أركز تاني على نقطة مهمة جدا اللي هي التايب of stitch material used in facial nerve grafting. Non-absorbable nylon 010. Sometimes the 010 is not available, so we can go down to 9 or 8, 08. Non-absorbable nylon stitches. دكتور أحمد عودة بيسأل in cases of bilateral facial paralysis which side you decide to go first. سؤال صعب يا دكتور أحمد، لكن أقدر أقول إن لو إن نادر قوي لما يكون الانجري of both sides at the same time, but if it happens, I will go for surgical repair of the more damaged nerve than the less damaged nerve. And for if they are sequential, I will attack and operate on the longer period of time unless it did not pass the 9 months period. نورتنا يا دكتور بيتر، سعدنا بمشاهدتك ونتعشى ان احنا نسمع منك كل خير. استأذنكم في الانصراف يا سادة يا حبايبي، واتمنى ان احنا نكون عند حسن ظنكم ونكون يعني افدنا واستفدنا. السلام عليكم.